Good morning, and thank you for joining us today. Today, we have Dr. Davey with us, who will be talking about the early detection of glaucomatous defects. Dr. Davey is a tenured full professor. Goodness, I can't speak this morning. He's a tenured full professor at Western University of Health Sciences College of Optometry. His doctoral work and postdoctoral fellowship were focused on management of glaucoma, particularly improving various diagnostic techniques. He is an active researcher, and his work is focused on retinal physiology and glaucoma, particularly improving visual function in disease states. He is a recent recipient of the Provost Distinguished Scholar Award for his research and grants in California Optometric Association's Young OD of the Year and Excellence in Optometric Education Awards. He has authored over 75 international publications and has given over 300 conferences and invited presentations both nationally and internationally. Next, we're going to cover some housekeeping items. So if you could please just refrain from entering any questions or comments in the chat feature and only use the Q&A, I'd greatly appreciate it. And the next topic is, if you need to contact Haag-Streit, we will be putting a link to contact Haag-Streit in the chat box. Additionally, I need to let you know that this meeting is recorded. And next, just some additional resources here. We'll also put in the chat function for you as well. If you'd like to register for any of the future programs for the perimetry month, which is going on all month this month in March. We'll also have the Visual Field Digest e-learning module and link to the PDF Visual Field Digest as well. So I encourage you to use those. Now I will go ahead and turn it over to Dr. Davey. Thank you so much, Dr. Davey.
Okay, thank you very much, Tanya, for the kind introduction. I'll stop sharing the results. Okay, good. The first few seconds in any webinar is scary if the transition doesn't take place very well. So I'm delighted to have you guys here as people are trickling in to the meeting. Let's go ahead and start the discussion. It is pretty fantastic to see these many dedicated individuals trying to learn more about perimetry and its correlations with structure and function. I'll try to be as exciting as a lecture as possible. It is early morning in California, and welcome. So there are numerous definitions for glaucoma, but none as simple and elegant as the one that is given by George Speight about 20 years ago, actually. Ocular tissue damage, at least partially related to intraocular pressure. The definition is elegant because what it does is actually says that at least some part of the disease process is still related to intraocular pressure, and we don't completely understand, and neither giving it too much of credit nor too little credit. To plagiarize Shakespeare, glaucoma, a rose by any name would actually smell so sweet, etc., etc. And one could just say, well, glaucoma is nothing but an accelerated loss of retinal ganglion cell axons. Well, but not so fast. It's not as simple as that. It is particularly different than other optic neuropathies. It is indeed the most common optic neuropathy. So the chances are, if you're seeing this optic neuropathy, chances are it's greater, much greater that it's glaucoma than other things, but it's one of many. And when you look at a nerve, if it appears very pale and less cupped, then you might be thinking other neuropathies. Whereas if it is cupped deep or cupped, and you can actually tell where the boundaries are of the nerve head and the rim tissue, then it's likely to be glaucoma. COVID has made us almost immune to statistics. You hear about these large number, millions of people actually getting affected, and we've actually lost touch with what 1 million people mean. And it's good to remember that it's a big number still. And glaucoma, at least in US, about 3 million, arguably about 3.5 million cases that are present. It is almost endemic to the extent that, we just accept it. It is present in large amounts. Ocular hypertensive patients are about 4.5% of the population greater than age 40. So at-risk individuals for glaucoma are quite a lot. And just general suspects that are looking suspicious because of the nerve head, or perhaps by visual fields or by pressure, you have a lot more of them, 4 times more than the glaucoma cases. But the point to remember is glaucoma still remains a highly undiagnosed or underdiagnosed disease condition. For every person that you know that has glaucoma, there is at least one another person that's walking around that doesn't know that have glaucoma. So we are already at 2020, past beyond. We have about 76 million worldwide and likely to increase to about 111 million by the year 2040. And what I know about statistics and disease is that we tend to usually beat all statistics much early than predicted, and which is not a good thing. So it's likely that you will see this number, 111 million people around the world, much earlier than 2040. There are various classification trees for glaucoma, but the reality is you have all these other secondary glaucomas, but the major cases that we'll end up seeing in our clinic are either primary open-angle glaucoma, normal tension, ocular hypertension, and of course the suspects, which forms a pretty large group of our patient population. So majority of the patients will end up falling in this category. There are indeed various risk factors to the disease. Most of them are not alterable risk factors, and aging is one of those non-alterable risk factors. Trust me, Californian plastic surgeons try to make you look young, but your risk for glaucoma doesn't change with change in looking younger. You have IOP, which is the one touted metric that has been constantly, time and again, in population-based studies shown to be an alterable risk factor in glaucoma. It is a fair question to ask, why is it the only alterable risk factors? Why not something else like diabetes, systemic hypertension, blood flow? And the answer is very fair. It's a very fair question, but at the moment, we do not have data that can systematically alter the course of the disease. We look at a nerve head. We start every patient by looking at their nerve heads, and something about the nerve head tells us abnormal, normal. We don't run visual fields on everybody, at least not the full extent. We may do screening, but not the full extent visual field. And so you look at a nerve and say, all right, it's cupped, it's vertically elongated, rim tissue is present. There is a little bit of absence of nerve fiber layer. And in our heads, we're comparing it to a very healthy nerve head and nerve fiber layer like we are seeing in the right side of your screen. The left side of your screen has definitely risk of damage visible. So let's go through a quick number of features that can tell you that a person's at risk. You look at a nerve head like this, you see a big juicy hemorrhage, no one's going to miss it. You see a massive nerve fiber layer defect along with it. Or you may see a large peripapillary atrophy, particularly 360 degree, like the one you're seeing and the yellow arrow is pointing out. Or you could see a certain bearing of circumlinear vessel. You can see this vessel is nicely curved, and yet there's a gap between the rim tissue and the blood vessel. Or it disappears for a little while and shows up in another location, which means that the cupping is way too big in the bottom. So these are like the hallmark features that you might look. Of course, vertical elongation is the biggest of all those features. Or you might see some subtle signs. Here in this patient, you see has a very shallow cupping. But if you look carefully and you looked at this in 3D, it's a pretty large cup. And you look at the blood vessel, the artery, particularly around the blood vessel, looks like it's being squeezed or constricted by some force from outside. As the artery actually progresses out further, it's much more normal thickness. And you can see such vascular signs. They are transient, they come and go. So most of us would confess that we use our nerve head as a biomarker to flag any suspect cases. But here we are to talk about perimetry, not about nerve head findings. And my goal is to at least rekindle the question that is nerve head all that we need, or we need other features, and if when utilized, the other features can give us dramatic data. So our agenda for today is pretty ambitious. We are going to look at all these things that I have talked about, and to some extent, you know a lot about it. But let's go ahead and start. So here, glaucoma perimetry foundations. Let me start with a poll to get you to start thinking about the question. So I'm going to launch the poll. And do you believe that the central retina is actually more protected in glaucomatous optic neuropathy? Go ahead, please. If you can answer the poll, looking at it. So the central retina is more protected in glaucoma optic neuropathy, given that most of us consider glaucoma to be a peripheral disease primarily. This is lovely. Quite a nice spread. Okay, just a few more seconds. Very decent size population attending today. Okay, I'm going to go ahead and end the poll. All right, and the answer, or the answer that won the popular poll is that 33% probably not, but it's quite a divided poll. I'm going to share the results. There you go. Okay, excellent. So 33% probably not, but quite a nice spread in understanding it. So I'm going to close this out and move on. Okay. Yes, there is some truth to that the central retina is more protected, but not as much as once considered. We are born a millionaire. We have about 1 million ganglion cell axons. It is quite a large variation. We could have anywhere from 700,000 to 1.2 million. And so it's have a large variation. What we are born with is a standard or a constant from which we are going to either maintain it or lose it. So we are born with an average about 1 million retinal ganglion cell axons per eye. Now, the arcuate fibers that you see occupy the superior and inferior temporal regions in the eye. Sorry, let's go back. But if you look at the peripheral axons as they actually come towards the optic nerve head, they occupy a bit more peripheral space in the optic nerve head. Whereas the papillomacular bundle, actually, which about the majority of the 50% of the axons come from that area, macula, they are spread across 1/3 of the distal, primarily in the inferior temporal region. But what we should not forget is these fibers intermingle with extramacular fibers. So they are not only in a particular location, but they also mix themselves with the other fibers. And that in part could explain the retention of vision in advanced glaucoma, vision measured by visual acuity. So these fibers are passing through and they are mingling with other fibers. So if the pressure, intraocular pressure, is pushing on the lamina cribrosa, these fibers have a little more support, and the fellow fibers may also die preferentially rather than the macular fibers. So the macular fibers have a little more protective, may explain the retention of central vision. But so many OCT studies now show that there is potential of macular damage. And visual acuity is usually the metric that we utilize in our clinical care. Visual acuity remains pretty good even in advanced cases of glaucoma. But if you check for contrast sensitivity, you would find that that is particularly declined even in early glaucoma. You don't have to wait till advanced glaucoma. Even in early glaucoma, contrast sensitivity goes down. So if visual fields are tested, you should have a damage, but we don't see it. Now, we have used Humphrey visual fields for so many years, and 24-2 has been utilized in research for so many years. And given that 24-2 Humphrey protocol has a very few locations that are being tested for the macula, you don't actually pick the defects as readily. And if you perform something like a Octopus G protocol, which has far more spots, so as to speak, as high resolution in the central region, you can pick glaucomatous damage very readily in the macular region. Now, thresholds threshold testing like 30 degrees, central 30 degrees are a standard of care. And most of us use glaucoma protocol. You could use a variety of other protocols as well in the central 30 degrees. So then we go into a question, is glaucoma a peripheral disease, or is it just all over the retina and not really a peripheral disease? Glaucoma is indeed a little more early detected in the periphery, but we don't measure visual field in 30 to 60 degrees. If you perform those tests, could we actually identify glaucoma even earlier? The answer is maybe not. The reason is that we are just not very good at doing thresholding, which is a pretty tough task to do in the way out in the periphery from 30 to 60 degrees. But if you do this research in laboratory, we can actually identify some patients and probably even earlier, but just general population in clinic, we're not so good. We try and do the dynamic protocol for all our patients because it gives you a better resolution and better follow-up care for our patient. Now, the top protocol, tendency-oriented perimetry, is pretty good. And if you wanted to actually get an idea of overall defect, or you have a patient that you just can't get them to perform standard visual fields, perhaps the top strategy should be selected. But most patients are okay with dynamic protocol, given particularly of the intuitive features of Octopus that learns to slow down the testing or even halt the testing if the patient has problems. All right, so let's go into early detection and glaucoma. Of course, everybody wants to diagnose glaucoma as early as possible, right? So let's go into this. Now, any irreversible, any disease that actually has potential of irreversible vision loss, you want to diagnose as early as possible. Because if you catch them early, you could do something about it. You may be able to give them medications, perform laser procedures, or surgery, invasive surgeries to change the course of the disease such that the person never reaches visual disability. Now, it's a big deal because when NEI actually polled, beg your pardon, it was NIH that polled patients with cancer, terminally ill cancer patients, what were they afraid the most about? And they were not afraid about dying, but actually losing their vision. So people give a lot of importance to their keeping and maintaining their vision. And it's almost impossible to function if you don't have good vision. So early intervention will prevent them from becoming blind. But if you catch them late, you have a chance of becoming blind. So let's go into the second poll where I want to ask this question. So I'm going to go into second poll right here. Now, do you think that structural damage has to precede functional damage in glaucoma? People say, don't know, surely not. Let's have a look. Okay, let's give it a little more time. The question is, do you think structural damage, meaning, you should see optic nerve head, nerve fiber layer damage, certainly before functional damage occurs? And it's pretty nice spread in the way that you usually expect it to happen. Okay, I'm going to end polling and I'm going to share the results, and nothing should be surprising. Most people think it is absolutely yes, possibly 39%. So the majority of the people actually believe that structural damage should precede before functional damage. And only about 8% believe surely not. So I'm going to stop sharing the results right here. I'm going to close and continue. All right, let's look at the fundamental question of what do I mean by structural damage before functional damage? You would expect the retinal ganglion cell axon to die and then functional deficits to occur before you actually see in glaucoma. So the cell dies first, then the vision goes second. That's very logical. I would have agreed to that story as well. However, we are not actually measuring individual retinal ganglion cell axons. We are measuring nerve fiber layer in a very macroscopic view. So here's an old publication of mine where I won't tell you, it's obvious, hopefully. So you look at it and say, which patient, which side of this is glaucoma and which side of this is actually normal. So here we compare healthy individuals, OCT fiber, with early glaucoma. It's kind of hard to tell which one's glaucoma and which one's normal. Looks so similar, right? X-axis exactly the same and Y-axis exactly the same. It's hard to tell. So let's put them on top of each other. That's the overlap you get in early glaucoma. So here's OCT data telling you in early glaucoma, with the current standards of actually utilizing nerve fiber layer structural measurement, we are not able to distinguish early glaucoma from actually healthy individuals. And the answer to this question is, why is this the case? Is if we were measuring individual retinal ganglion cell axons or photoreceptors, we would be able to pick up the damage. But we're not. We're looking at it very macroscopically. Give you another example. I have shoulder pain right now, and if you go do an MRI, X-ray, etc., let's say X-ray, you may not find any problem with my shoulder, but I have pain. So functionally, I can tell you I have pain, and you will be able to see that in a patient. But structurally, you might not find any damage because the structure measurement is not sensitive enough to identify the damage. And so we actually see this time and again, that early glaucoma looks very similar to healthy patients. In fact, Oates' study showed this very nicely. Oates' ocular hypertension treatment study showed that by looking at the optic nerve head, stereoscopically, mind you, not by just monocular, stereoscopic optic nerve head evaluation, only 55% of ocular hypertension patients were identified as changing into glaucoma as a first step. 35% of them showed visual fields as a first sign of conversion to glaucoma, and only 10% actually showed both optic nerve head and visual field. What that would mean is that if you only performed disc nerve head analysis, you are likely to catch 65% of the patients. If you performed only field analysis, you would probably catch 45% of the patients that are converting. And only if you perform both, you're likely to catch them all. So in reality is structural damage does not necessarily precede functional damage, because the structural measurement that we are using is not sensitive enough. And the structural measurement here we discussed are either looking at the nerve head or looking at the nerve fiber layer thickness. So what do we do for these patients? Perform visual fields and have an open mind. If your visual field shows you a consistent damage that is repeatable, you need to look at that person suspicious enough and definitely follow up the patient. Now let's go into a new form of perimetry, the pulsar perimetry. Exciting stuff. The concept is not new. The concept of targeting specific ganglion cell axons for detecting damage is quite an old concept. This is brought out using a particular target called the pulsar target that specifically picks up magnocells, and it's very comfortable to the patient. So let's discuss why testing specific ganglion cells may identify damage early. So you have a white target on a white background, and so long as, and we have actually a lot more than 3 kinds of ganglion cells, but the majority of them either are parvo, conio, or magno. We have about 80% of cells in the retina are parvo. You have about 9% are conio. Magno cells, you have around 9% as well. So you add them up, it's about 98% of the cells in the retina are parvo, conio, or magno. If you have a white target and a white background, so long as you have some cells in that particular region alive, you are able to going to see the target. So here you see, for example, I'm not saying magno cells die early or preferentially. All I'm saying is if some magno cells were dead and some other parvo were dead, but there are other conio and some parvo cells present, and you would still detect the person saying, yes, I can see in this region. Whereas if you use a pulsar target, which specifically targets magnocells, then there are very few to begin with, 9%. And if you have a few cells that are dead, you can readily pick up the damage. And the way the pulsar target is designed is by phase change. You see a white ring and a black ring, white ring and a black ring, and this white ring is changing to black, and the black ring is changing to white. So there's a phase change of the kind of white to black and black to white. And a healthy person sees it, whereas a person that has a damage or disease cells will not see it. You can change this by changing the contrast, changing the spatial resolution, how tightly the rings are packed, how loosely the rings are packed. And you can actually tell if you can do thresholding. So here's a case, for example, here is standard automated perimetry, white on white. You may identify maybe there are some possible regions of damage. You can see some regions, 1, 2, 3. You're not sure. You perform specific ganglion cell perimetry like Pulsar, and you're able to see a nice superior arcuate defect along with some nasal step in this particular patient. So Pulsar perimetry has some serious advantages. Pulsar perimetry is in fact resilient to more optical blur. So if you don't get your refraction perfect, or it's close to it, you're okay. It is also more resistant to cataract-related blur because magnocells are more resistant to cataract-related blur, and they are less affected when a person has cataract. You may be able to detect glaucoma early, and in fact, if you have very early or suspicious kind of glaucoma, the pulsar perimetry is going to show a much more greater defect when compared to white-on-white perimetry. I'd like to tell you one thing with caution. This is designed for detecting early damage. If you already have a patient with moderate level of damage or advanced level of damage, you're going to see all black in pulsar perimetry. Person can't detect the target at all. For patients who are moderate to advanced level of damage, please use the white-on-white perimetry on Octopus 600, and that's the way to go. So moving along, I'd like to go into structural-functional correlations. A quick coffee drink. So, structural functional. If you are looking for this word in dictionary, you're not going to find it because it is a combination of structure and function. This is a made-up term, which is called structural function correlations. Most people treat structural function correlation like the game that the kids play called the rock, paper, and scissors. So kids have to actually say whether they actually make a fist, and they say they're going to do a rock, or they're going to do a paper or scissors. Something beats something. So either the rock would actually beat the scissors because it can break the scissors, or scissors can cut the paper, or the paper actually beats the rock because rock may have no effect on the paper. Now, the problem with this understanding of structure versus function is that people argue structure probably precedes functional damage. We saw that. We tried to break that argument. Or perhaps function precedes structure, or maybe both occur simultaneously. And we've already figured out saying that that's probably not the case. So then we go asking, so how do I correlate this and get the best results? So let's go to age-old question. Let's look at structure and function in greater detail. You have a patient right here. You can look at the visual fields. It's Humphrey. I just wanted to make a point. You look at the right eye, has some nice superior arcuate defect. Left eye has a massive loss. And you can see in the grayscale and the total deviation plot, the pattern deviation showing white because it thinks that everything is due to cataract. It's probably not due to cataract, and that's an artifact. You look at their OCT and you find that they're pretty flat and very similar to each other. So the right eye and left eye is so similar to each other on OCT. Now, structure and function, they actually are not the polar opposites. In fact, there might be a slight gap in structure and function following each other. So in very early glaucoma, one can say that majority of the cases might show structural damage first, and then function is maybe a little bit behind, depending on the kind of function you test. Look at the tail end where you see advanced glaucoma, you're going to see OCT is going to show a flat line. Everybody is going to show a flat line Whereas visual field is the only way, one of the only ways that you can follow up very advanced damage in glaucoma. So if you look at this and say, well, in early glaucoma, there might be a slight difference. In advanced glaucoma, there is definitely a slight difference. But in the middle of the range, structure and function is running parallel. So it depends on how you actually correlate them. You can get incredibly robust results in this. 20 years ago, Ted Garvey-Heath proposed the Garvey-Heath plot, which is known now as different parts of the rim tissue correlates with different parts of the function. Now, if you do have a Humphrey visual field, you can do this in your head, and you have to be a particular genius to be able to correlate each time. Now, the Octopus perimetry does a fantastic job of actually plotting the damage in visual field to a proportionate plotting in where you would expect in your OCT and optic nerve head analysis the damage to be. So here, if you're having a damage in the superior region, you're going to expect this damage in the infratemporal region in your OCT, perhaps even on your fundus photo. So looking at that a little bit closer, you can, okay, let's look at this carefully. You have all these lines showing that this is a region of potential action. You can look at the fundus photo in this patient and clearly see a notch in the optic disc and also a corresponding retinal nerve fiber layer defect, very beautifully visible on the fundus photo. And you can compare them up and say, all right, that's exactly where I am seeing the majority of the damage. So the Octopus brings structure and function measurement closer to each other, and makes it a lot easier for clinicians. So let's look at some more unique features, because that's not the only feature that Octopus perimeter has, which is unique. Some of the unique features of Octopus are, you look at cluster analysis, and I'm a huge fan of cluster analysis these days. After examining so many patients and looking at their total deviation, pattern deviation plots, cluster analysis really helps very nicely. So the reason for this cluster is you look at this and say, man, this looks like the nerve fiber layer plot that we saw early on. And the idea is that to divide the Octopus visual field into 10 different sectors that are a cluster of a particular band of nerve fiber layer. So here you have the superior arcuate, you have the inferior arcuate fibers, you have the papillomacular bundles, and individual points may actually vary, but the cluster as a whole is very stable and robust. And it closely represents, it's not an accident, it's done by design, it closely represents the pattern in the nerve fiber layer to give you a better structural function correlation. So let's look at some examples. So here you have, and this is taken from Gabor Hollow's Journal of Glaucoma paper. So you look at a patient and say that, okay, this is a paracentral defect, a couple of probability plots. You can see it's not really reaching the threshold. You want at least 3 or more. And if you look at the cluster analysis actually is outside normal limits for this particular patient. So as individual points are there, may not reach the threshold of glaucoma suspicion, but you look at an overall cluster and you say, all right, definitely a superior arcuate defect is possibly forming in this particular patient. You look at this patient further, and then you can do polar analysis, and you can find out, all right, 7 o'clock position should be the region for the action. You look at the fundus image, you can see a hemorrhage present on that particular patient. And if you did OCT, you might actually not find necessarily a optic nerve head damage in nerve fiber layer. But if you looked at ganglion cell complex, you might find as the papillomacular bundles progress into the macular region, there is definitely a damage present there. So here's an example where the cluster analysis really helped you seal the deal. And along with polar analysis and a little more of OCT digging, you can convince yourself that this person has damage. Here's another example of the patient where you're seeing early stage glaucoma defect. This is from the Octopus perimetry book that I highly recommend you guys download. And you might show that there is a central defect, a little bit of paracentral defect, significant amount of cluster damage, indicating a possible nasal step. You are looking at polar analysis and you find The polar analysis also showing you damage at 7 o'clock to 8 o'clock position. The baby A plot is showing you a sudden drop right here. We'll come to baby A plot momentarily, and it tells you there is possibly a localized damage that you can see in the ganglion cell complex region of the OCT as well. So very helpful in looking at things together and combining structure and function data to convince yourself. Now, OCT is good. We all are in love with our OCTs. Having done many OCT studies myself, we are actually in awe of our OCT. But visual fields is truly the only technique that the patient is telling you, I don't see in this region. And it's convincing you that they have a problem. For example, a patient that has a superior arcuate defect and is driving a car should be more careful in actually not going really fast, because they will not see the signs on the road until they get closer to the sign. So that's an example of something that you can warn your patient. Or a person that has inferior arcuate defect, you want to really tell them, watch out when you walk down the stairs because you're not going to see so well. Make sure you turn the lights on. So these things that are specific for the patient, you can actually tell the patient, and that could really save a fall or an injury, and which makes visual fields very, very crucial. Now, visual fields have got a big bad rap because people say, oh, they're variable, and there are some reasons why they are variable. So let's look at these reasons why they could be variable. Fixation errors leads to big reliability issues. So visual field indices, we have fixation losses that we look at, false positive, false negative, all these things that we actually look at. We look at eye tracking, head position, and they are good, but they're very elementary, almost very old school. This was probably being formed when I was still in my high school. And it was good for its time 25, 30 years ago, but not so much. 25 years ago probably was state of the art. You looked at Humphrey perimeter, and then you actually got, if there is you track the blind spot using the Hale-Krakow method as a first step. And if the eye moves, you find that you get the squiggly line that tells you how much the eye has moved. Machine doesn't adjust anything. Machine just leaves the data as is. It's up to the doctor to actually look at this and say, all right, I want to accept this visual fields or not accept this visual field. Whereas the Octopus perimeter has been, for the last decade or more, been utilizing immediate and current techniques of adjusting the machine to the eye movement. So for example, if there's an eye movement in the patient, the machine adjusts the patient's position immediately, which allows for a better fixation of the patient. In fact, if the patient closes their eyes, or God forbid they fall asleep, what happens is you actually can tell that the machine actually stops the testing. So if they close their eye, then the machine stops testing. So it definitely doesn't give you garbage data. All right, so this can prevent a lot. The latest Humphrey CETA-FAST does not even have some of the fixation monitoring techniques, which makes it very difficult to follow a patient with that. So Octopus perimetry far and ahead in stopping the test and giving you reliable data. So that's very good. The baby A curve has been always part of Octopus perimeter, has not been implemented in other visual field techniques, but gives you a visual picture of what the patient's visual field looks like. So they're ranking the best seeing spot to the worst seeing spot. So here you have the best seeing point, here you have the worst seeing point, and they're just ranked. If they fall between these two lines, they're considered to be normal. If they fall away from that, that could be abnormal. So here's an example of a diffuse defect, a person that has a curve of baby A curve, which is very parallel, but no localized defect. In this patient, you are seeing the baby A curve is parallel to some extent. So you have a diffuse loss, but you also have some level of localized loss. So let's look at this in detail. So here's a normal one. It's perfectly normal. Here's a patient with a diffuse defect, possibly indicating that this person has a cataract-like defect. Here's the person with a localized defect. So you can see the curve is within the lines, and then it's falling down abruptly. Or here's the patient that has both localized defect, which you can see by abrupt fall, but you also see a generalized defect. So person has a little bit of cataract or pupillary miosis, and definitely has possibly a localized defect present. So it certainly helps you in that fashion. So if you look at this, the G protocol that we utilize gets you a nice idea of, here you can see in the corrected probabilities plot that there is a defect present in the superior arcuate as well as the nasal step defect. And you can see the Baby plot is telling you exactly that. You can see it is within the lines and then suddenly drops down, being abnormal. So, and macula is, of course, represented very appropriately. If you see a patient with a severe macular defect, you can run the macular protocol additionally to G protocol if you're worried about a fixation split or a major fixation or central defect in this patient. For now, COVID is here to stay. At least we can't see the end of this. And we need to be aware of some amount of the cleaning protocols, which makes it very crucial. So when you use Octopus perimeter, if you're using an Octopus 600 or 600 Pro, it's fantastic. You just use isopropyl alcohol 70% to clean the surface. It's fully enclosed, less chances of contamination of the perimeter, less chances of transmitting disease from one patient to another. But if you were using Octopus 900, you don't want to use isopropyl alcohol in the bowl. And the reason for that is that you could actually damage the perimeter and change the level of contrast between the target and the background. So you want to use soap suds to clean if the perimeter has a spot, but don't rub, just clean it a little bit. And you can always ask your technician to contact Haag-Streit to get an evaluation. But here the key is the patient is wearing a mask. When the patient is wearing a mask, you don't actually get the droplets inside, so less chances of transmitting the disease. Plus, there is no air flowing out of the perimeter, which decreases the cross-contamination between the patient. But wearing the mask, you can actually make the lens get fogged. So the key to remember is to tape the top part of the mask so that the lens is not fogged. If the lens gets fogged in the lens holder, then you could actually create artificial defects, which you cannot explain. So make sure that the patient wears a mask when they do Octopus 600, but certainly tape the top part of the mask so they don't actually blow air and fog the lens. The Octopus 600, you just use isopropyl alcohol 70%. Why are we using isopropyl alcohol 70%? Why not 100% isopropyl alcohol? Well, the 100% isopropyl alcohol doesn't penetrate the cell membrane of the contaminant organism. So in fact, 70% kills the organism much better than 100% isopropyl alcohol. So use 70%. A quick third poll, let's talk about future of perimetry. Okay, so we always want Haag-Streit and Octopus have always been in the cutting edge of perimetry. Do you think a virtual reality perimeter, like a goggles or something that a person is wearing and sitting in a comfortable chair, is the future of perimetry? And that is something that Haag-Streit should consider, or you are hoping for it to be possible? Okay, let's go ahead and end the poll. I want to share the results. And it's not surprising. Perimetry is very important. And as we get a more aging population, we are likely going to require virtual reality devices that allows a patient to do it comfortably in a chair rather than bending into the perimeter bowl. The virtual reality perimeter or tight perimetry also gives the advantage to do some home monitoring for the patient, where the patient can do this between visits. And so it is not surprising that almost 90% of them feel that yes, 30% absolutely, 60% hoping for it to be possible. So majority of the people think that that is probably the case. I would love to know from the people that thought it's unlikely the case, why they feel. And please use the Q&A to give your comments, which will be very helpful, I think. All right, so let's go into, I'm going to stop sharing the results. I'm going to go into a quick few cases that we saw before the COVID hit the fan. And let's take a few examples to drive the case of early detection and how structural function correlation helps us a lot. So here you have a patient that we have seen not so long ago, almost a year ago because of the COVID, where we saw that we did OCT on them and found early damage in this patient. Now, this patient's been followed up for a while, and we are seeing they have both inferior loss in nerve fiber layer, superior loss, vertical elongation, as well as some parts of the OCT falling significantly outside normal limits. Now, you might say that, okay, so surely this much damage, you should be able to see ganglion cell complex damage. And that's not the case. You can see the ganglion cell complex is pretty normal in this patient. So it doesn't have to be that even structural correlation should correlate with each other. Now you do visual fields on this patient, and you find there is a nice paracentral defect superiorly. And look at the other eye. Other eye shows a much more significant inferior damage. And you can see the ganglion cell complex values are green, indicating that they are within normal limits. But if you look carefully at ganglion cell complex, you can see that somebody else has taken a bite out of the OCT right here. Visual field indeed showing you superior arcuate-like defect forming in the corrected probabilities, and the probability plots are very similar to each other. You can tell that this person doesn't have much of a cataract. This is a patient that is very likely showing you damage in both this, saying that the cataract is not the cause for the loss. And so this is an example of an early defect. I want to move this away, and you can see how the Baby A plot is also showing you a damage that is occurring in this particular patient. So moving this away. All right, so that's an example of an early defect. Let's look one more example where the early defect is even more earlier than the ones that we saw. So you look at this fundus photo. Now I do have stereo pictures for this patient. We just don't have stereo goggles. I'm not sure everybody has it, so I didn't bring that, and I used monocular pictures here. So here you see the right eye and the left eye of this patient. You can see there's a pretty nice thick rim in the right eye. You can say that there's at least inferior thickness is at least equal to the superior, but in the left eye you can see a distinct vertical elongation of cupping, definitely showing you that there is a slopy rim right here, maybe. But actually probably no rim or very little rim there, inferiorly compared to superiorly. So there's definite damage. So now what does the OCT look like for this patient? So we expected some level of damage, but certainly not from the fundus picture monocularly, that this was showing you a nice inferior superior loss on OCT, right eye. And the left eye is also showing you some level of damage inferiorly, as we expected in looking at the stereo viewing. Certainly some parts of the nerve fiber layer definitely following outside normal limits. Now, if you look at this OCT, these are not particularly large nerve heads. They're very, look at the disc area, they're average sized nerve heads. They're not large nerve heads. So they're not megalopapillae. They are pretty average sized looking nerve heads, very symmetrical, right eye and left eye. So this damage that you're seeing inferiorly is significant for the particular patient. You look at this visual fields now and say, all right, it's falling. It looks like the Baby A curve is saying that they are depressed overall, but certainly there is some level of a localized damage present in the left eye as well. So you look at Baby A curve, you look at corrected probabilities and say, not making possible, but not showing exactly the case. So what can we do with this? So go to your polar analysis, and you can look at the right eye and look at the incredible cluster right there on polar analysis being formed, saying there is possibly damage right in the supratemporal region, exactly where you would expect the damage to be. You can look at these red lines, they're crossing the gray area, indicating that there is potential damage in the supratemporal region. Now, you look at one isolated infratemporal damage and say, I can't see it from OCT, but there is inferior nerve fiber layer, which is falling in the borderline. So wonder what kind of damage should you expect in this region? Visual field is showing damage. OCD is not. Let's look at the other eye. And you can look at the infranasal defect being formed right here. There is also some level of damage in the supratemporal region, which the OCT is not yet picking up, but sometimes OCT actually follows. Now you look at angiography on this particular patient. Now OCT angiography is the cutting edge, but Europe is far ahead than US in this area, and you've had the OCT angiography for much longer and approved. But you look at OCT angiography image on this patient, and everything seems to be fine. You don't see a particular region that's falling outside normal limits. So angiography, which is supposed to show potentially early damage, does not show much at all. Last case, ocular hypertension. The patient had elevated pressures. We performed visual fields and OCT as a baseline. And you can clearly see in this case that there is certain specific region in the OCT that is showing damage, which corresponds nicely to the visual field damage on the polar analysis plot. And so we can question ocular hypertension patient and say, even though the global indices are saying this person is quite normal, localized indices are saying that they are potentially abnormal. So watch these cases closely, perhaps even consider treating if needed, if the pressure is and where you might actually feel that this is probably not glaucoma. You also have to understand that structural function does not always correlate, but they can't be completely opposite to each other. They are going to match if you do the right kind of visual fields testing. You have to do multiple testing to actually catch the patient, and sometimes, and quite often, visual fields will catch it earlier. So do it early, do it on every patient. Use Pulsar perimetry that can help you in tricky situations. You want to get them diagnosed early enough, but make sure the Pulsar perimetry is not utilized in advanced cases. Use progression as your methodology. If you see a change over time, it may be very small, but if it's repeatable, it is the hallmark of glaucoma. And remember, doing the same old thing again and again is not going to give you any better results. You have to try something new. Look at the perimetric techniques like G protocol that may really make your case for you. So I'm going to stop sharing right now, getting Tanya back on the discussion and taking the Q&A.
Excellent. So thank you so much for that presentation. That was a wonderful discussion. We will go ahead and turn it over to questions now. So if anybody should have some questions, please feel free to enter those into the Q&A section. We'll be happy to answer any of those questions that you have. At the moment, Dr. Davey, it doesn't look like there are any questions in the Q&A. So I'll give it a few moments, and if no one has questions, then we'll go ahead and end. Remember, for all the participants, that there are links in the chat section to contact Haag-Streit, to register for the Perimetry Focus Month, as well as downloading the e-learning module and the PDF for the Visual Field Digest. I'm just going to give it a few more moments here for folks to have an opportunity to enter some questions into the Q&A. Otherwise, we will close out. Any final words from your side, Dr. Davey?
No, this is brilliant. Thank you. Let's enjoy the Perimetry Month. And you guys know it. I'll just say the same thing again. We should question dogma. Anytime somebody says that this is the only way, you have to question the dogma, and only then we would find the true causes, the reasons, and really help our patients. So there's one question that popped in. Thank you, Dr. Windsor, for the comment saying that it was a good lecture. Hope to see you guys at a conference live someday. And thank you very much, Tanya.
Yes, thank you. Since there are no further questions, we'll go ahead and end the session. Thank you so much for attending, Dr. Davey. Thank you so much for your wonderful presentation and joining us today.
It's my pleasure.